Good morning. This is the House Appropriations Committee. It is the last day of February, February 28th, 2025. Friday morning, it's 10 o'clock, and we are delighted to have with us Dr. John Soroyan, if I'm pronouncing your name right, and Addie Armstrong to talk to us a little bit about the Blueprint for Health. We have a lot of requests and things in the budget, and we are not the healthcare committee, so we're going to be educating ourselves today. So we really are grateful that you were able to come today. We'll go around and introduce ourselves because I don't believe you've ever been in our committee. So start with Dave.
Good morning, Dave Iacovoni from Morrisville. I represent the Lamoille, Washington District. Greetings.
Morning and welcome. I live in Burke and I represent the Essex Caledonian District.
And your name is?
No, that's okay.
Oh, yeah.
Yeah, threw me off. I was gonna go there, Jim. That's okay. I represent Texas.
Mike Nigro. I represent Bennington and Pownell, and it's really nice to see you, Dr. Soren.
Tom Stevens from Waterbury, representing the Washington Chittenden District.
Good morning and welcome. Jim Harrison from Chittenden and also represent Mendon, Killington, and Pittsfield.
And I'm Robin Shy from Middlebury.
Tiff Lumley from Burlington.
I'm Randall Rush from Franklin. I represent Highgate, Franklin, Berkshire, and Richford.
Good morning. I'm Mike Berwicki and I represent the Wyndham 4 District of Putney and Dummerston.
Next to Mike is Representative Dickinson, Lynn Dickinson from St. Albans Town, and then just in time to introduce himself.
Trevor Squirrel, Underhill and Durham.
Well, thank you. Good morning, Chair Shy, and thank you for inviting us. I'm John Soroyan. I'm the Executive Director of the Blueprint for Health. Just briefly about me, I live in Norwich, Vermont. I'm a pediatrician by training. My subspecialty training was in hospice, palliative care, and pain management for children. In 2013, I left my academic practice at Columbia University and moved to Vermont to do adult hospice in Vermont and New Hampshire, where I continued through 2022 when I joined the Blueprint in 2022. So, Dr. Armstrong?
I'm Addie Armstrong, and I'm a PhD in math. I got my PhD from University of Rhode Island. And then after that, I taught at Norwich University. I've taught at the community college in New Hampshire, and I worked in consulting for a sock factory that we've all heard of in the state. I've worked for the DoD. I joined Dale in 2022 to run the Data for Money Follows the Person. And then I moved over to Print in 2023, where I've been able to work on operations research problems.
Very lucky to have Dr. Armstrong. We have 3 program managers, Michelle, Emmy, and Connie, representing Burlington, Middlebury, and Barry. So they're here and listening in and supporting us. So I'll start. It's okay.
Please, and we all have on our desk, and you've got it up there.
Thank you. Please don't hesitate to stop me if needed. The aspects of the Blueprint that I'd like to leave you with today that I'm going to say at the beginning, I'm just going to move this part of my screen so it doesn't block it, is that Blueprint for Health focuses on building best practices in primary care practices and subspecialty practices across the state. There are practices in all of the districts that you represent, in all of them. The services are accessible to patients regardless of payer. The 2 core aspects of the Blueprint for Health that I'll describe in greater detail is the patient-centered medical home, which are very high national standards for the practice of medicine, and multidisciplinary community health teams. Other initiatives that have developed, I will review. And lastly, again, if I leave you with just a few things, Medicare, Medicaid, and commercial insurers make payments to support these initiatives. It's a multi-payer model. At the center of that model is the Vermonter who goes to a clinic, a practice. It could be a federally qualified health center, could be a private practice, it could be a naturopath, it could be a hospital-owned practice. And for the most part, all the concentric circles and other circles that are surrounding that person to support them, they're usually not aware of the Blueprint for Health, the funding mechanisms, and the other teams that are provided. So, for example, we have program managers here today, which oversee the administrative entity, which enacts our program in a health service area, which I'll show you a map of next, under the rubric of the Vermont Blueprint for Health. The state, for a Blueprint, oh, this is so great that I have screen in front of the back. is divided into hospital service areas. We've listed not only the name of the hospital service area here for you, but also the federally qualified health center or the hospital in that area that administers the program. Planned Parenthood of Northern New England is considered a 14th health service area since it serves the whole state. Okay, so I'll go through the initiatives and then go into greater detail on each of them for you. As I said at the outset, patient-centered medical home is a model of providing high-quality primary care. That's national standards that the practice has to follow. The clinic, that's the site. Community health teams, that's the first part of Blueprint that I ever heard about when I first moved here and started practicing as a hospice physician. This is just an example. The community health team in Rutland thinks this person needs a evaluation for hospice. The community health team in Windsor thinks this person, I was a hospice provider. So for me, it became part of my vernacular right away. I didn't even know what the Blueprint was, which is okay. I knew that there were community health teams that were referring people that needed a higher level of care because they were approaching end of life. The hub and spoke system of care, which is a model not just for Vermont, but also for Vermont to treat individuals with opioid use disorder. So individuals who've become dependent or perhaps even addicted to prescription pain medications, to fentanyl. And the hub and spoke model is something that I'll dive into a little deeper too. More recently in 2017 is the Pregnancy Intention Initiative, which I'll also speak to, which supports pregnancy intention and family planning. And then new in 2023, there is a mental health integration initiative embedding support specifically for mental health, addressing things like housing, transportation into primary care. So patient-centered medical homes at a very sort of direct, concise level are national standards that a practice must attest to for their standard operating procedures. Access, coordinating care, preventive care, and really making sure they're taking care of their whole practice population, not just going problem to problem to problem. That model of care nationally and in Vermont has proven to have had improved clinical outcomes. So for example, management of certain chronic conditions, greater patient engagement and follow-up and treatment, getting to their appointments yearly, and some of the data that Dr. Armstrong's going to share that we've been fortunate enough to have her do with our population, decreased utilization of the emergency department. Our community health teams appear to a patient as a social worker, a nurse care coordinator, a community health worker, a nutritionist. We've just diagnosed this with you. We want to pair you with this person who's a member of our community health team. Some of the health service areas label that Blueprint, some of them don't. And I'm fine either way, as long as I know that the funding is being used the way it's supposed to be used, tailored to that committee. They can do brief, short-term mental health counseling. They can support management of chronic conditions. They can coordinate care and look at that whole person to let the provider, whether it's a nurse practitioner, a PA, an osteopath, a physician, move on to their next patient and know they've got a team taking care of them. The Spoke initiative is the aspect of opioid use disorder that the practices that we have among the Blueprint can participate in. And then they get extra team members. They get additional community health team members to serve that person so that the person has a counselor assigned to them. They have a nurse care coordinator that gets funded from Blueprint dollars. So not only are they there for their primary care, but they might be getting treatment for opioid use disorder. Across the state, there's 91 practices, many of them that are already part of our patient-centered medical home that also provide this level of care. Also, there's addiction specialty sites or clinics that also participate in the Spoke program. The Pregnancy Intention Initiative, very similar to focusing on opioid use disorder in terms of being very much embedded in our primary care model, spans the gap not only from primary care, so that extra support, that other level of screening for social needs in primary care, but also in obstetric offices. So this is actually where Blueprint has been able to move beyond simply primary care, which is not simply, but also to specialty care, so that individuals can receive counseling and screening that might get pregnant, that might want to get pregnant, and look at those options related to it. New in 2023 was a one-time appropriation for the mental health integration into primary care. This was something that was very much recognized as a need in the state, nationally, increasing suicides, increasing death from opioid use disorder, and an expansion of the hub and spoke model to include other substances beyond opioids. So take that model, but make it work for other types of issues too, and really grow that aspect of our community health teams to counselors, social workers, and community health workers. And that's been a pilot that's just been a tremendous honor to oversee and watch the successes come back from on. Just a couple quotes, and then I'll move to some slides before I go into Dr. Armstrong. This is from a counselor in Barrie Health Service area who works in that opioid use setting. The work we are able to provide is critical to the support of patients and our providers and local spokes. I have had primary care providers tell me this is the most rewarding aspect of their job, and patients say, "You've helped save my life." A community health team staff member in Brattleboro, we are able to meet people with people who need it. Again, the community health team can meet with individual regardless of their insurer. We are connected right to primary, or even if they don't have insurance, they meet with them, connected right to primary care so they feel comfortable with us. There also isn't a copay for our support, so they don't have to worry about the money component. I know we are helping people. It wouldn't be possible without the blueprint. And finally, a pregnancy intention initiative worker in the Burlington area. Our wraparound care had the benefits of preventing an emergency department visit, a potentially lengthy hospital admission, and increased hospital costs. I hear that story over and over when I speak to our community health teams. What are the funding mechanisms? How are these initiatives funded? Two terms I'm not going to dwell on too much, but that I want to say and sort of put into context. Training as a physician, working in other states, prior to coming to Vermont, fee for service. That's the term. The service is provided, a fee is charged. Some of it goes to the individual person who was served. Some of it, if they have insurance, goes to the insurance. Blueprint is based on prospective, so ahead of time, value-based, population-based payments, per member per month payments. And the way that's calculated, and I'm only going to say this briefly, is by an attribution methodology, which Addie and her team helped to do, looking at which patients are assigned to which provider. And then these payments are based on that population within the practice. So it's not a fee-for-service based model. It's a value-based per member per month model for attribution. And this is important as I lay out some of the dollar amounts for you that come from the different payers. So Medicare has paid into that national standard, that patient-centered medical home model, as well as our central first community health team initiative. That's been allowed by an agreement with CMS that's ending this year. Commercial insurers, Blue Cross Blue Shield of Vermont, Cigna, and MVP also pay into that core patient-centered medical home program, as well as community health team initiatives. Plans that fall under the federal law called ERISA from the 1970s. So this is self-funded plans, Medicare Advantage, any employer basically that chooses to pay for their own sort of healthcare rather than using an insurance company. They do not pay into Blueprint. Those individuals receive services regardless of their insurance. And then some small insurers also do not contribute. And then Medicaid, the base, pays into each of the initiatives and is the only payer included in the mental health integration. From this slide, what I find is most helpful. So if you really want to get granular, you can see the dollar amounts per program, per type of payer, per member per month. But I think the example at the bottom is the most important part of this slide. And the reason I say that is because I think depending on where one is seen or what practices are around where one lives, and if 75% of Blueprint practices have an attribution number of around 100 or at least that size. So for example, that practice would be receiving payments between $4,500 and $5,000 a month for participating in the Blueprint's high standards, and their community health team members, whom they choose with their local program manager, would be funded at about $50,000 per year to support the practice. About 20% of our practices are at least double the size, but this gives you, I think, a sense of magnitude in terms of those dollars coming in month over month, quarter over quarter, that again are population based, they're not fee for service based.
Oh,
Yes, please.
For you, Dr. Sorry. The community health team, is that one team? So is it $50,000 once, or is it if they have 4 people or groups? I'm not sure I'm using all the right language here, but
Okay, that's okay.
no, is it 50,000 per each sub-member of the team or group?
So the dollar amount is based on the attribution count that the insurer has calculated. And so the dollar amount comes in based on numbers served. Go ahead.
Do you want to say-
Yeah, sure.
So if it's essentially, we think of it as per practice. So for a 1,500 patient practice,
Right.
we expect that practice, the community health team is a broader organization that supports lots of practices.
Yeah.
That team would receive about $50,000 for that practice. If there's another practice that has another 1,500 patients, be another $50,000.
Okay.
And so that's how it can support so many workers, because it's kind of per practice.
Okay.
And, it might be 1,490 patients, and then it's a little less, but it's a little different.
Okay. And then how do you define an attributed patient?
Sure.
We pop back one
Yeah.
slide, I think.
Yeah, just,
See if we can.
there we go. So the number of members a payer is make payments on is determined by the insurer's attribution to a Blueprint practice. Do you want to go through it quickly?
Sure.
Yeah.
So insurers actually are the people who calculate the attribution. We set the algorithm, we say, this is how you should count, and then they look at their data and count. And an insurer will look at the last 2 years of all the claims submitted by all the doctors in the Blueprint and say, okay, Jane went to this doctor 14 times. And did she have the right codes? Was it primary care? That's the most. So Jane is attributed to this doctor. Now, if Jane goes to 2 doctors, it'll take whoever she saw the most, basically. And so it's saying, okay, who did you get the most primary care from over the past 2 years? And that's how someone is added to that count.
So it's related to primary care specifically.
Right. There's a
Codes,
specific list of codes, of procedure
long.
codes. It's a very long list. I don't think you want.
10 or something.
We
Yeah.
review them every year, or
We review them every year.
Yeah,
We add and
it's a lot.
subtract and take away and.
But the focus is primary care. So if you just saw the dentist or you just saw the eye doctor.
great question.
You
Yeah.
wouldn't be.
Or you had a broken wrist, but you never saw primary care. That
Exactly.
didn't count.
Yeah.
Exactly. And because of that, there will be occasional patients who, if they have arthritis, they might get a lot of their care from a rheumatologist,
Yeah.
but they might see a Blueprint physician every now and again.
Yeah.
They're not going to be counted for that. So most of their care and their rheumatologist, their annual physical and all those things. Okay, well, they might actually go, but they're not going to be
Right.
counted as attributed. And that's because we try to make sure that each provider's only getting paid for one patient, doesn't get counted twice, so that we're not like suddenly, saying, you went to 6 different doctors, they all get money. That's a little complicated.
Right.
It's a tiebreaker.
So I'm trying to understand the chart you had up. Payment. And looking at this real quickly, it looks like the lion's share of the payments are coming from the Medicaid program, which is state dollars, I assume, plus federal dollars. And what's the $163? Are we paying that for every Medicaid? No?
Not every patient, no. So that's specific to the spoke opioid use program. And so not everyone will have an opioid use disorder. And so it's only for those patients who are receiving treatment for that disorder at those practices. That's actually a fairly small program.
Medicaid's paying $163.
If they have that disorder and they're being seen in a practice that's part of our program and they receive a prescription of either buprenorphine or Vivitrol, then that triggers that amount.
Okay, so let me ask you another question, which you may not have an answer for. But, everything we're seeing and hearing is Vermont has now the highest insurance rates for healthcare in the country. And the trajectory is going in totally the wrong direction. Should we be suspect of all our best intention efforts that, we have the Green Mountain Care Board, we have Voices for Care, we have the Blueprint, the folks are involved with. Are these saving us money or are they just adding to the cost? And I don't expect you to answer
Yeah.
all that, but specifically on the Blueprint.
Sure.
Which started, I want to say back when Jim Douglas was.
2005.
Yeah, have we made it worse? Just, I don't know if there's an answer to that.
Okay.
I mean, how do you justify whatever that, whether it's $3 a month or whether it's, $5,000?
There's a whole section, the end of our slide presentation to shed some light on your question. Yeah.
Okay, so Mike Murphy and then Mike Nigro.
Thank you. Thanks for coming here. Probably segueing a little bit from what Jim had to say, and I go back when I was on Human Services Committee. My understanding of the blueprint at that time, more than 10 years ago, was we had identified a cohort of people who were regular users, especially of emergency rooms. And the idea was to bring teams in to focus on that. And try and update me, I'm trying to understand who you're serving here. Is everybody in a practice that's identified? Is it people who are identified as heavy users? And then my second question is, going back to what I've learned about trauma through my own work, and are these identifiers, whether it's adverse childhood experiences or other trauma identifiers that help identify people who are getting extra help service?
Sure, we can, thank you. We can shed light on the emergency medicine or emergency room question in Dr. Armstrong's slides. And the answer to your second question, and I don't think we'll go into as much detail today as you might like, but the individuals are identified right now mostly by their clinicians, but also by screening instruments that are administered to identify what you're talking about exactly.
Just a clarification, the commercial insurers that are paying into Blueprint, is there something that requires that, or do they?
Legislature.
Okay, so I was going to say that. Thank you.
Statute, yeah, thanks. So this is an overview slide again of what the amount was in 2024. As the representative mentioned, Medicaid supporting all the initiatives, commercial insurers and Medicare supporting those core initiatives. And at the bottom, just to label it a one-time appropriation for that mental health integration. May I turn it over to you?
Absolutely.
Okay. Oh, sorry. Yeah, go ahead.
Health integration was one time, and how long is that going for? Or
It was a 2-year
24.
pilot for which there's language to make it a 3-year pilot. So any remaining funds may be used.
Right, and we just, instead of having an end date, it's until the funds are used up.
Yes, that is correct.
I've seen that language.
Okay.
Now we know what that's for.
Just want to, again, on that chart with the dollar chart, following up, 2 questions here. So what's the mix of patients? What's driving the attributed money?
Sure. Dr. Armstrong has a slide exactly for that, a beautiful pie graph, so we can show you that.
In fact, I think that's the first thing that you'll see.
Oh, true.
So this is, I like this part. I get to talk a little bit about the impact, the data, the numbers. What are we doing? What does all this buy? And so this shows you who's paying into the Blueprint initiatives per quarter. And these numbers are based on all the commercial, and these are our initial. We know that Medicaid is the only payer into spokes and pregnancy intention. So I'm not going to show you a chart that's just the center right blue bar that says Medicaid. I'm going to just show you this one. The green bar is Medicaid in this chart. And as you can see, it's been going down a little bit. Why did it start going down? If you recall, we started determining whether or not people were eligible for Medicaid last year. That's what's happening. So we can see that green bar shrinking. The central bright blue bar is our commercial insurers. It's between 100 and 150,000 a year, a quarter. And I don't have the data for last quarter yet. They're a little slower to report to me. So I'm waiting on those numbers, which is why that last quarter has that star. The commercial data is not yet available. And then
We have a question here.
No, you can finish your
Okay.
sentence and then
yeah. And then the bottom bar is the Medicare portion, and that's pretty consistent in the 77, 80,000 range, depending on the year. Go ahead, and then I will.
Sure. Well, maybe you will address this later on, but I'm just wondering what you're thinking about what we're hearing from Washington about Medicaid and how this affects all of this.
So a lot of the stuff is fairly recent, and I think a lot of us are still processing and thinking going forward what, as an agency, we're going to do. So honestly, that's a much bigger question. It's not a question that I can pull an answer to and just say, this is how the agency is thinking, but we can take that back. I'll let John speak to it if he has better ideas.
I'm following very carefully and listening to my leadership too, Representative. I think that, I welcome your input.
Well, I guess I'm just wondering, is this particular type of programming especially vulnerable? Because it's a kind of special Medicaid, it's not core Medicaid. Or is it core Medicaid?
Not in my view in terms of all of our policy work, but I again, as Addie said, there's a degree of, I think, unpredictability that I can't see into, but not in my professional opinion.
I totally appreciate that you don't have a plan. But I wondered if you knew about the particular vulnerability of this program.
Yeah, I could certainly bring that back to our policy folks, but in terms of our approval and our policies, we're very up to date with the feds.
Yeah, and so the 1115 waiver is Vermont's Medicaid kind of agreement. And as long as that's in place, this is part of the 1115 waiver work. So it's subject to the same vulnerabilities as essentially all of the Medicaid services covered under 1150, which is Vermont Medicaid as a whole.
Right, but that's the big question. I don't know the answer to that.
And
So it's vulnerable.
I want
Everything is. Okay.
So one more thing I'm going to mention on the slide is because of Medicaid's redetermination, we've been seeing those numbers go down a little bit. We have actually been seeing that central bright blue bar go up a little bit. It's hard to tell when they're, stacked like this, but there is a little bit of lag time. So we do expect, instead of the trend to continue going down, we kind of expect a little bit and then it to go back up, because people, when we calculate that attribution, these are the numbers that are calculated, not just visits. So somebody's on Medicaid, they get off Medicaid, Medicaid's not counting them anymore. They got on their commercial insurance, they got a new job, but they haven't visited the doctor yet this year because they visited the doctor while they were still on Medicaid. And so there's no claim in the system for them. So there's sometimes a little bit of lag time between when people change insurance. And so that's, I think, a little bit what we're seeing here, as opposed to, we certainly know that the number of people in Vermont is not decreasing. And we certainly know that the number of people visiting doctors is not decreasing. So that doesn't mean that we're decreasing here.
Another question or Dave?
With the one care no longer practicing at some point, the administration has recommended a certain amount of funds to go towards primary care as a bridge in a sense. Should those dollars that are targeted for primary care that used to go to one care, should they be routed through the blueprint and directed toward attributed lives, because we know those patients are getting best practice?
I think we have yet to determine how those monies will be routed out of AHS. But I don't know the answer to your question. Should they be? I think the priority is seen right now is filling the gap from the all payer agreement ending and those Medicare dollars flowing to primary care practices as they were. That's my understanding of how it's been written. Should it be turned into blueprint payments after that? I guess is up for discussion still.
You don't have a recommendation.
I see. I see the answer to my recommendation being tied to the AHEAD model, which is a significantly higher per member per month payment than what it is now. So I don't have a good gestalt for you right now.
Thank you.
I will add one thing to that, if I may. The 10.8 million line item in the governor's recommended budget, half of that is to support blueprint payments. So those funds are already being routed through the blueprint in some way.
So those are not dollars, but rather part of what was coming through OneCare?
Yes. That was part of it. It was not all of it, but that was part of it. Yes. OneCare did administer a lot of the blueprint's funds. The Medicare portion in particular administered all of that because it was very convenient for them to do the essentially check splitting. They got the big check from Medicare, split it up in all the ways. And then now that big check has to go.
Just a follow-up, if I may. So the various payers, they channel the cash, the dollars to you?
In different ways.
And
So
you distribute the funds?
no,
It varies.
it varies.
But there's not a, no, we direct the funds, and generally we direct the funds as how they go from the payer to the practice or to community health team funding. We direct them. Doesn't come into a
Yeah, we
pot
don't
that I
get a
hold.
pot.
You should. Thank you.
May I go to the next slide?
Atkinson and then Rep. Stevens. And I'm just gonna let you know that three of us are gonna have a committee of conference at 10:45.
More
So,
importantly, we're losing.
oh yeah, so we actually have to, that's right. Well, much more importantly than the committee of conference is that we're losing Aaron. So we're gonna have to end this at no later than 20 of. In fact,
I have several questions. I would like to hear about the emergency department because I know that's a huge issue. But one of the things that I question at first, it looks like your payer mix just by looking ahead. It looks like there's about even between commercial, Medicaid and Medicare. There is probably other types of, that's actually not too bad. That's better than some hospitals have.
Yes,
And certainly no nursing homes have that.
yes.
One of the questions, and maybe other things, one of the questions I have is when you do the, one question is that my understanding is when you go with a capitation plan, which is an attributed, that it isn't just like you give them the money. You actually do in the background a fee for service analysis because you have the codes and you have to know what was done when and what the intensity was and what the procedure was and what the details were. And that helps both the provider and probably Blueprint and anybody else who's interested to know how much it costs to treat these patients. You've got attributed there. It's not just like I get $5,000 and I just give it to them and they do what they want. There is an accountability piece to that. So you're doing a double type of thing here. You're doing your capitation money. You're also somewhere in there, everybody's still got to do fee for service to account for what their P&L is. How does that work? Or do you?
So the payments for the blueprint are not actually a capitation model for the services provided.
Right.
Those are all still fee for service. The payments for the blueprint are that additional payments to ensure that higher quality. We'll talk about the ED visits,
The community plans
time,
and all that.
right, the
Yes.
community health teams, these
Yeah.
things. And so, yes, there is a fee for service model that goes on in the background that informs the attribution. That's how we find out who got their care and where they got it and how many people belong. And then,
And how much money it's going to cost so that you can adjust accordingly.
right, although we have not had the opportunity to adjust our rates in recent years.
Okay, yeah. The other thing is there was an audit done by the auditor. And he seems to indicate that there was savings early on, but it's really hard to tell if there's any savings now. So have you reached your maximum amount of savings and now everything else is just not there anymore? Or how does that work?
I think we welcome the opportunity to speak to that in greater detail in the future. I think there was some distance on the conclusions and where the blueprint stands on that statement, though we wholeheartedly agree with the recommendation. That would be a point by point that I'm not sure I'm prepared to go through right
We
now,
will not be talking about that right
but
now.
I'd be happy to in the future.
But I'm trying to jump ahead. Can you talk about the emergency room issue?
Absolutely. That is the next two slides.
Wayne had a
So I
question.
want to jump ahead to the next two slides.
Okay.
Just, and then the next one, just,
I'm sorry, but there we are.
next one's mental health and substance abuse, then the next set of graphs down, the next slide. Or one more
Yeah,
slide.
so let's do the emergency room visits, which is
So the graphs here, now I'm assuming these are the emergency room cases. And it looks like roughly 30% of the cases in there are either mental health or.
So these are patients with a mental health or substance use condition. The slide right before this one goes through kind of how people end up in that category. Yes.
So my point is, that I want to make is, what I'm asking is, what criteria for success and failure do you have with this program? And we have a great concern about emergency rooms being all filled up with mental health and substance, well, mental health especially, substance abuse in some cases, but they actually need it for medical care. But it's a major problem with our hospitals, we understand. Could you speak to that?
So I'm going to talk a little bit about this slide, and then I'll add a little tidbit about something else that I've been able to do recently. So this slide shows you the proportion of patients who have a mental health or substance use condition. And there's a giant list that people throw out through that SAMHSA, diagnosis codes, all those things throughout. And the difference is not huge, but it is statistically significant. And that's kind of one of those things that is important to us. Statistically significant means it's unlikely to be random. If we pull all these people again, we're going to get the same answer. This is not a random difference. So one of the things that we're tracking is these people with mental health and substance use conditions tend to end up in the emergency room at a higher rate than people without mental health and substance use conditions. This graph on the right-hand side shows the rate at which these people had those visits, the proportion of people with an ED visit in that condition category. The green dashed line, of course, is the non-blueprint patients. The blue line is the blueprint patients. You can see that apart from the COVID year when we had this nosedive, when nobody went out, the difference is significant and it's slower. Blueprint patients end up in ED visits less. That saved about 4,500 to 5,000 ED visits last year. And so I don't have off the top of my head how much cost that is, but you can think of it, we've avoided some ED visits. And that's useful. Go ahead.
I'm concerned when somebody says there's a significant difference and they don't tell us what the p-value is and what you're trying.
So the p-value on this is 0.001, which means it's a 99.9% chance that it's not random, and a 0.1% chance, 0.1%, that if we did this again, we would see a difference. And this has been that significant for the past 5 years.
Got your answer.
Other questions?
Okay, we literally have 2 minutes.
Okay, so I will mention this one. This is the number of encounters. So what are encounters happening? Community health teams are providing services, about 300 to 400,000 services a year. And when we say a service, we don't mean they called you and reminded you you had an appointment. We mean they provided a brief intervention. They did some counseling. They taught you how to manage your diabetes. Something actually happened. And so those, I think I'll wrap it up there and just kind of point out that that is some of the things that are happening. We see that as a significant contributor to why our folks are ending up in ED visits less.
Okay, and then we have the payer mix on the next page.
And the last page was who's doing this work and what each item is paid for. Yeah.
Sorry we had to rush you at the end. It's really interesting. We are getting a lot of emails from folks who clearly believe that this has been a critically important program, and this shift from ACO to AHEAD has its challenges. So thank you for all you are doing. Clearly you're making a difference in people's lives. So thank you all. And thank you for coming in. If people have other questions, I don't know if we want to stay around, we'll go off live, but if you want to